thank you so much for inviting me to speak tonight about my passion, genetic counselling. Tonight I'm going to define what genetic counselling is, describe who should be offered genetic counselling, describe the genetic counselling and genetic testing process, review cancer predisposition syndrome that involve inherited breast cancer, and do a brief overview of insurance coverage and genetic discrimination, and I'll finish with future directions in genetic counselling and testing. So 1 year ago, an article was released or written by Angelina Jolie. I'm sure most of you have heard of it or read it. It caused what we call the Angelina effect. A lot of people now know what BRCA1 and 2 genes are, or at least have heard of them, and now have heard about genetic counselling and testing. So this is a very timely presentation this evening. So what is genetic counselling? It's not a therapy session. It's an information or teaching session to provide an individual with the information they need to provide informed consent to have a genetic test. So who should be offered genetic counselling? Well, any woman with a diagnosis of breast cancer at a young age, for example, under the age of 50, any woman diagnosed with triple-negative breast cancer, any woman with a diagnosis of epithelial ovarian cancer, any person who's concerned about their risk for developing breast cancer or other associated cancers, including male breast cancer, ovarian cancer, prostate cancer, and anyone who's of maybe Jewish ancestry with a personal or family history of cancer. Why should you consider genetic counselling? Well, genetic counselling may clarify your risk for inherited cancers. It may also provide options for medical management, such as targeted therapies, which include PARP inhibitors, and Dr. Trosa Sandoval is going to talk about those later. It may also have implications for family members with respect to screening and risk reduction options. What is involved in genetic counselling is the process should include the assessment of risk using personal and family history information, and provides education and counselling. It should be conducted by a physician, genetic counsellor, or other specialist with expertise in cancer genetics, and it could include genetic testing, if desired, after the appropriate counselling and consent is obtained. It is the most informative to test an affected family member for inherited predispositions to cancer, as this provides a better interpretation. And when possible, the test should be ordered by a genetic counsellor or a specialist in genetics, as we have the expertise to sort of interpret the results, which can sometimes be not straightforward. When I see a patient for genetic counselling, I usually see them in 2 sessions. At the first session, I take a medical history. The pathology of cancers within the family is important, and I'm going to talk about that later. I confirm and expand the family history, discuss and interpret the risk assessment based on that family history, review the genetics of the particular inherited syndromes that might be appropriate for that family, and discuss and facilitate the options for the appropriate genetic test or tests. At the results session, I provide the results, discuss and interpret the limitations of testing, provide screening recommendations, discuss risk-reducing surgical options, and make the appropriate referrals to the specialists. And we discuss possible strategies for informing family members about the results. The most important screening tool that we have really is family history. So when you meet with a genetic counsellor, they're going to ask you who in your family, be it brothers, sisters, parents, uncles, aunts, have ever had a diagnosis of cancer. And they also ask where you're from, what your ethnicity is, because that can also help target our testing process. This is what a picture of your family history looks like. We call it a pedigree. Circles are females and squares are males. When we draw out the family tree, we shade anyone with a cancer diagnosis because that gives us a vision of what's going on within the family. Unfortunately, cancer is very common, so most people have a family history of some description. We see sort of generally 3 types of families. This one over here is a sporadic family history where there's one person with breast cancer within the family. Again, because cancer is very common, I often see this familial clustering of cancers. And then on the right is a clear hereditary predisposition to breast and ovarian cancer. As I mentioned briefly before, verifying the family history and often the pathology of cancers within the family is really important for our risk assessment. For example, if someone comes to me and said, well, they think that their grandmother had ovarian cancer at 35, but then go away and confirm that actually the grandmother had or aunt had cervical cancer, that totally changes the risk assessment, as cervical cancer, for example, is not inherited. And if someone, sorry, I jumped ahead. If someone says that they think their grandmother had a mastectomy for breast cancer, but they go away and they find out that grandmother actually didn't have breast cancer or had surgery for other reasons, again, that changes what we say to the family. And this sort of documents often what I see within my clinic. Someone will come and say, well, I think my aunt had liver cancer and I think my grandmother had stomach cancer. I ask them to go away and try and confirm this for me. And if they change it to this particular family history, as you can see, my aunt had breast cancer, my grandmother had ovarian cancer, that clearly changes the risk assessment and the appropriateness of testing, and also helps with insurance coverage if this is confirmed as well. The limitations of a family history, though, do include if we have a small family, if you have a paucity of female relatives, and we are talking about breast ovarian cancer mainly for the women, and adoption or non-paternity. So what is involved with genetic testing? Well, it's really a blood test. It can also be performed on a saliva sample, but we do prefer blood because we get better DNA, better quality of DNA, and better amount of DNA. And in some other different tests, we can do tissue tests. The turnaround time can range between 2 to 4 to 6 to 8 weeks, depending on the number of tests or the different type of tests that we order. And the testing protocols can vary centre to centre, but at Memorial, we usually do it as part of a 2-step process. The initial consult and genetic risk assessment, as I described, and the results consultation. So, as I said before, most cancer is not inherited, only a small percentage of cancer is. I'll just give you a little bit of background. When we're thinking of genetics and genetic testing, it's important to understand that in every single cell of our body, we have chromosomes. Chromosomes contain our genes, which are made up of DNA, and that genes make a protein, and it's the protein that does the function in the body. When we do a genetic test, we're actually looking at the DNA of the gene, looking for a mutation, which is a change in the normal sequence of the DNA letters. And that's what we're looking for when we're doing a genetic test. There are a number of genes that are inherited. When you have a mutation that's inherited, cause familial predispositions to breast cancer as well as other cancers. The main ones, as I'm sure all of you have heard, would be hereditary breast ovarian cancer syndrome, which are the BRCA1 or the BRCA1 and 2 genes. And there are other syndromes listed here that I'm going to briefly talk about later. There are also some moderate penetrance genes that we've discovered. These genes provide elevated risks above population level for breast cancer, but definitely nowhere near as high risks as the genes I'm going to be talking about in detail in a moment. They include ATM, CHEK2, BRIP1, PALB2, NBN. There's a number of them now that are available for clinical testing. So BRCA1 and BRCA2, hereditary breast ovarian cancer syndrome. How common are the BRCA1 and 2 mutations? Well, within families with breast cancer, about 10% of women with breast cancer under 35 might have a mutation, 10% of women with under 45 with a family history, and about 10% of all women with ovarian cancer. The red flags for hereditary breast ovarian cancer syndrome include young or early onset breast cancer or breast cancer under 50, triple negative breast cancer, and Dr. Trosa-Sandoval is going to talk about that later. Certain ancestral backgrounds. If you have premenopausal breast cancer and a close relative with early breast or ovarian cancer, male breast cancer, prostate cancer, or pancreatic cancer. And if someone has ovarian cancer with a family history of those cancers as well. When we're thinking of BRCA1 or 2 associated cancers, this is sort of the latest data I pulled from a website called Gene Reviews. The latest data says that if someone has a mutation in BRCA1 or 2, you have up to about an 80% lifetime risk of breast cancer. With ovarian cancer, it does differ the risks between the 2 genes, up to 40% for a BRCA1 carrier, up to 18% for a BRCA2 carrier. The risk for male breast cancer is higher in a BRCA2 versus a BRCA1 carrier. There's also an elevated risk for prostate cancer in these families, as well as pancreatic cancer within these families. I mentioned before about ethnicity. When we're looking at the genes, and this is a cartoon diagram of BRCA1 and BRCA2, mutations can occur anywhere along the lineup of these genes, but we know that within the Eastern European or Jewish population, there are 3 mutations, these two in BRCA1 and this in BRCA2, that are the most common within that population. And we actually start testing for those 3 first if someone reports Jewish ancestry, and then continue on testing for other mutations within the gene. There are found mutations not just in the Ashkenazi, but in the Icelandic, the Dutch, the Hungarians, the Irish, Scottish, and other ethnic groups as well. So why do you want to test for mutations in BRCA1 or 2? Well, it can help people guide decisions about their breast cancer treatment. BRCA carriers can be more sensitive to platinum chemotherapy. There are these targeted therapies that, again, Dr. Trossel-Sandoval will talk about. It can guide decisions about screening approaches, be it annual mammograms and MRIs for a BRCA1 carrier, 1 or 2 carrier who's not had a breast cancer diagnosis, transvaginal ultrasounds and CA125s as ovarian screening in a woman before she's ready to finish having her children. It can decide decisions about preventive surgery. In a BRCA1 or 2 carrier, we do recommend removing the tubes in the ovaries after childbearing, because unfortunately the screening we have for ovarian cancer is not effective. And there's also the option for mastectomy as a prevention. It can define potential at-risk family members. If we find a mutation in BRCA1 or 2, each first-degree relative has a 50-50 chance of sharing that mutation and therefore the associated cancer risks. So we can really save lives by knowing this information. And it also provides reproductive choices. It can be controversial. There's a technology called pre-implantation genetic diagnosis. Using IVF, it takes 1 cell from an 8-cell embryo, test it for the known mutation in the family, and you only implant back the embryos that do not have the mutation. Again, it's expensive. It's not for everyone. This is an adult onset condition, and it's not covered by insurance most of the time. But it's a technology that's available, and some people have chosen to do it, so we at least inform patients about this technology. So I'm going to leave hereditary breast ovarian cancer syndrome for now, and I'm going to briefly talk about other breast cancer predisposition syndromes that we sometimes test for in our clinics. There's a syndrome called Lee-Fraumeni syndrome, which involves cancers, a multiple number of cancers. The P53 gene, or the TP53 gene, is a very important gene within the cell. And if someone inherits a mutation from their mother or father, or it starts in them, a mutation in every single cell of their body, they unfortunately have a lot of lifetime risks for develop a number of different cancers, be it breast cancer really young, like in the 20s sometimes, leukemias, sarcomas, brain tumours, and sometimes colon cancer. A woman diagnosed with breast cancer before the age of 30 might have a 2 to 7% chance of having a P53 mutation, so this is sometimes discussed with patients. Because of the significance of this syndrome, about 50% of patients who we discuss this with don't proceed with testing. That's a pretty scary one to think about, but it is rare too. There's another syndrome called Cowden syndrome. Women or men for this syndrome have high risk for benign or malignant tumours of the thyroid, breast, and endometrium, obviously in women. Affected individuals can have macrocephaly, which is a large head, some skin findings. But the lifetime risk of developing breast cancer is about 25 to 50%, with the average age of diagnosis between 38 and 46 years. And that's just some of the skin findings you can see with Cowden. Hereditary diffuse gastric cancer is caused by mutations in the CDH1 gene. This causes elevated lifetime risks for this diffuse gastric type of gastric cancer. The average age of onset for that is about 38 years, and unfortunately those patients do require gastrectomies. Women also have a 39 to 52% risk of developing the lobular type of breast cancer. Peutz-Jeghers is it's a rare syndrome, but it is is caused by inherited mutations in the STK11 or LKB1 gene. About 8% of women with Peutz-Jeghers develop breast cancer by the age of 40, and 32% by the age of 60. So the cost of testing and insurance questions. So as I said, the test is usually performed on a blood test. It can be performed in a number of different laboratories, and again, the laboratories vary around the country, and most of them offer, you know, the BRCA1 and 2 genes now, plus all of the other tests that I mentioned. So the turnaround time, depending on the number of tests that you order for a patient, because families don't always fit into one category. You can sometimes have families that could be leukemia or could be hereditary breast ovarian cancer syndrome. So it can be 2 to 4 to 6 to 8 weeks or longer, depending on what tests we order. Insurance companies, if a personal or family history fits the national guidelines or fits like Medicare guidelines or the particular insurance company's guidelines, they will cover the cost of the testing, and obviously it depends on your out-of-pocket or co-pays that you might have. But it's not always covered, so it's always important that you check, get the procedure codes from the genetics team and speak to your insurance before doing the test. And we can always provide those procedure codes. There's the HIPAA is a privacy, protects against discrimination. It's a privacy thing, a form that you sign that protects you, and the Genetic Information and Non-Discrimination Act also protects you against discrimination in the workplace.